Hello, and welcome to the Community Health Worker Diabetes Learning Module. My name is Madison Kelly, and I am a PharmD candidate. And I also have Ashley McKecken, a pharmacist, and Haley Pruden, another PharmD candidate here with me. This module is brought to you on behalf of the Illinois Pharmacists Association. To help educate you on the management of diabetes, we are going to use the ADCES 7 Self-Care Behaviors Framework. This framework is integral for the self-management of diabetes and other related conditions. ADCES is the Association of Diabetes and Care and Education Specialists and is one of the many organizations that provides recommendations and resources for diabetes education for both educators and patients. For section 1, we are going to start with the history behind the language of diabetes, and then we'll move on to the physiology as well as some definitions, and then some risk factors for developing diabetes. Historically, the term diabetic has been used to describe a person with diabetes. Within recent years, there's been a shift in the diabetes community towards using person-first language, such as persons with diabetes over diabetic, to emphasize the individual rather than the condition. Changing the language we use when referring to patients with diabetes can help reduce stigma and help us build better relationships with our patients. However, patients may have a personal preference of one term over the other, but it is important for us to use the patient-preferred language when speaking to or referring to the patient. The pancreas is the primary organ involved in diabetes. Later, we will discuss how other organs are impacted by diabetes. But the pancreas has numerous roles for our body's normal physiology, including releasing hormones, digestive enzymes, insulin, and glucagon. The pancreas regulates the amount of glucose in the blood by either releasing insulin or glucagon. The two work inversely to alter glucose, where insulin decreases the blood sugar and glucagon raises it. Now let's go over some quick definitions to help build up our diabetes dictionary. The term prandial refers to mealtime, so preprandial is before a meal and postprandial is after a meal. Fasting refers to a time period without food. Hemoglobin A1C, often shortened to HbA1c, is a lab marker, and it's collected as a percentage, and it estimates the average glucose over the span of 3 months. BG refers to the blood glucose, which is the amount of glucose present in the blood at a given time. The term glycemia also refers to the amount of glucose in the blood, where hypoglycemia is a low blood glucose and hyperglycemia is a high blood glucose. These are terms that are important to know when speaking to other healthcare providers, but lay terms such as before meals and after meals should be used when speaking to patients. Now let's move on to differentiating between the different types of diabetes. The two we most commonly see are type 1 and type 2 diabetes, so we'll primarily focus on those. Type 1 diabetes is caused by an autoimmune reaction where the body's own immune system destroys the cells that produce insulin. Type 1 diabetes has historically been called juvenile diabetes. However, this language is no longer used to avoid that misconception that the onset of type 1 diabetes only occurs during childhood. While detection of type 1 diabetes usually is during childhood, the onset can occur at any age. There's little to no insulin production in the presence of type 1 diabetes, and it will require lifelong treatment with insulin to prevent complications and to maintain body function. Type 1 diabetes often presents as an acute illness and has symptoms such as excessive thirst, frequent urination, and unexplained weight loss. Unfortunately, type 1 diabetes is not preventable, and numerous genetic and environmental risk factors can cause it. Type 2 diabetes is due to cells becoming gradually resistant to the effects of insulin. Onset of type 2 diabetes is usually in adulthood, but we are seeing a steady rise in the prevalence among adolescents. Insulin production can vary in type 2 diabetes, where insulin production still occurs earlier on, but slowly decreases to little or no insulin production over the progression of the disease. Type 2 diabetes requires interdisciplinary treatment with lifestyle modifications and potential medication therapy. We will discuss medication options for diabetes later. Diagnosis of type 2 diabetes is often delayed due to the lack of symptoms, which is why routine health screenings are so important for our patients. The longer type 2 diabetes progresses before diagnosis, the more difficult it may be to manage. Type 2 diabetes can be prevented with early intervention and lifestyle modifications, but genetics and numerous environmental factors play a large role as well. Looking at some more definitions, glucose is the body's preferred source of energy, and it is integral to our everyday functioning. We obtain glucose from the foods we eat and our body's natural glucose stores. Insulin is a hormone that is produced by the pancreas that allows our body to use glucose as energy. Think of our cells as a locked safe. There is a lock on our cells called a receptor that keeps our cells closed. Insulin acts as a key to open up our cells and allow glucose from the bloodstream to enter them. Once this glucose enters our cells, our body can then use it as energy. Glucagon is a hormone produced by the pancreas. When our blood glucose is too low, the pancreas releases glucagon to send signals to the liver to prompt it to release hepatic glucose to be used as energy. In the case of diabetes, there is an imbalance in our lock and key mechanism that we were discussing earlier. Simply put, diabetes is due to an excess amount of glucose in the blood. This excess glucose can be due to a problem with our key, where the body produces either not enough or no insulin, or due to our lock, where the body does not respond to insulin correctly. This is what is known as insulin resistance. This slide is just a quick recap of what we went over in the last slide. In people without diabetes, you can see how our dietary intake of glucose and the release of insulin from our pancreas allows our muscles to adequately use glucose for energy. In patients with type 1 diabetes, we see that the muscles are not able to effectively use glucose as energy due to the lack of insulin production from the pancreas. This explains why fatigue and exhaustion are commonly seen in patients with uncontrolled type 1 diabetes. In the presence of type 2 diabetes, we see that the muscles are not able to use glucose due to insulin resistance. So we have come to our first learning check for the module. Feel free to pause the recording and restart it once you have your answer. The question is, which of the following best describes insulin resistance? A, the pancreas does not produce insulin. B, cells do not experience the effect of insulin. C, there's too much glucose in the bloodstream, so no insulin is released. D, there is not enough glucose in the bloodstream, so no insulin is released. So if you answered B, you would be correct. Insulin resistance is where the cells do not experience that effect of insulin. Now let's talk about some risk factors for diabetes. People who have a family history of either type 1 or type 2 diabetes are at risk of developing it themselves. There are also numerous genetic variations that increase a person's risk of developing type 1 or type 2 diabetes. Patients who already have autoimmune diseases, such as Hashimoto's or celiac disease, are at risk of type 1 diabetes. The presence of islet autoantibodies on the pancreas is usually indicative of type 1 diabetes. Finally, certain environmental triggers, such as viral infection and early diet exposures, can contribute to the risk of type 1 diabetes. The second column describes risk factors that are only specific to type 2 diabetes. So having certain conditions such as prediabetes, gestational diabetes, high blood pressure, high cholesterol, or PCOS can increase a person's risk of developing type 2 diabetes. Lifestyle factors such as body weight and activity level are also associated. Certain racial and ethnic groups face a disproportionately high risk of developing type 2 diabetes, which can be attributed to factors such as socioeconomic barriers, systemic inequities in healthcare access, and varying levels of health literacy. It is important to note that these disparities are not biologically inherent, but reflect broader social and structural influences that impact preventive care, early diagnosis, and chronic disease management. So section 2 is going to be the bulk of our content. So we're going to continue using our ADCES 7 self-care behaviors as our outline to ensure that you're receiving that well-rounded, comprehensive diabetes education. These 7 self-care behaviors include healthy coping, healthy eating, being active, taking medication, monitoring, reducing risks, and problem solving. So starting with healthy coping, getting a diagnosis of diabetes is life-changing. So we need to provide compassionate and judgment-free care to all of our patients with diabetes. Unlike many chronic conditions, diabetes often requires around-the-clock monitoring. Because of this, patients are often burdened with that task of self-monitoring. And it's easy for patients to get overwhelmed when managing their diabetes. So between that constant monitoring, medication administration, and lifestyle management, diabetes quickly becomes ingrained in every aspect of their life. So it is our job as health workers to make sure that these patients manage their diabetes and that they can live a fulfilling life that does not feel controlled by their condition. So this slide is a chart highlighting some common and unhealthy coping habits, as well as some healthier alternatives we can recommend to our patients. Behaviors like smoking, overeating, or substance use may contribute to unhealthy coping, while practices such as meditation, faith-based engagement, and participation in support groups can more effectively enhance patients' coping skills. Now let's talk about the importance of being active. We want to encourage our patients to engage in some form of daily physical movement. This doesn't have to mean going to the gym or running marathons. What matters here is consistency and finding ways to move that fit into their lifestyle. There are a few simple strategies we can share with patients. First, be safe. We want to make sure that the activities they're doing are both appropriate for their health status and their abilities. Second, we want to fit activity into their daily life. So this could be something as simple as taking the stairs, walking a dog, parking their car a little far away, stuff like that. Third, we want to start with small steps. We need to remind patients that they don't need to do everything at once. Even a 5 to 10 minute difference in their activity can have some major impact on their life. Fourth is plan it out and make it happen. So building that activity into a schedule increases that follow through. And finally, be creative and find fun, enjoyable ways to move so it feels less like a chore. On the right side of this slide, I've included some key terms that can help us when talking to our patients. For example, metabolism is how the body uses food for energy. Cardio refers to activities like walking or swimming that can help raise the heart rate. Resistance training helps build muscle and strength. Balance exercises can help reduce fall risk, especially in older adults. And stretching improves flexibility and prevents injuries. The goal here is to empower patients and see activity as something flexible and personal, so something they can adapt to their own needs while still getting those health benefits. The primary components of our diet or macronutrients include carbohydrates, fat, and proteins. Carbohydrates, or more commonly called carbs, are found in food such as bread, pasta, and fruit. The body processes carbohydrates into glucose to become energy. The carbs are the main macronutrient that play a role in mealtime insulin dosing. Fat is found in foods such as oils and nuts. The body uses fat for long-term energy storage, as well as some other functions. And then protein is found in foods such as meat and beans, and the body uses proteins to help repair and build tissues and muscle. So looking at healthy eating, we're going to take a look at a nutrition label here. So the weights and daily percentages of each nutrient are listed on every food package. It is very important for patients using insulin to calculate their carbohydrate intake prior to administering their mealtime insulin. Some resources that are helpful in counting carbohydrates are Carbs and Cals, Snack, and My Sugar. This slide is a visual depiction of which foods are in which macronutrient category. So you can see that there's even some overlap, like in the case of beans, they're both high in protein and carbohydrates. So now it's time for our second knowledge check. Please pause the recording until you come up with your answers. So we have John here. He is a 7-year-old boy who has diabetes. His favorite foods include steak, macaroni and cheese, avocados, and bananas. Question 1 is, what type of diabetes does John likely have? And then question 2 is to classify each of John's favorite foods into their respective macronutrient category. So just based on the information provided, John likely has type 1 diabetes. Steaks are high in protein, macaroni is high in carbohydrates, and cheese contains both protein and fat. Avocados are high in fat, and bananas are high in carbohydrates. So this knowledge check further reminds us that many foods contain multiple macronutrients, just like in cheese. We saw both protein and fat there. And now I'm going to pass it over to Ashley so she can tell you about diabetes medications.
Thank you, Maddie. Hello, everyone. My name is Ashley McKecken, and I am going to talk to you today about the general considerations for diabetes medications. It is important to know the common side effects and also the risks that are associated with each diabetes therapy. These therapy options are typically tailored to patient-specific goals as well as their preferences. Now, these medications do vary in their ability to lower A1C, their risk of hypoglycemia or that low blood glucose, as well as their ability to cause patients to either lose or gain weight. Certain medications can also be beneficial or actually potentially harmful to patients based on their conditions as well. This slide does show a picture of the different mechanisms by which these medications can lower blood glucose level. This slide is for your reference only, so please feel free to pause the presentation at this point and review the material when needed. The first medication class that we are going to look at is our sulfonylureas. Now notice how all of these medications do start with the letter G, and they all do end in the ending "ide" or IDE. Some examples of these medications do include glipizide, glyburide, and then glimepiride. These agents do have the potential to cause that severe hypoglycemia or low blood glucose levels, as well as weight gain, and they are actually taken before meals to help decrease those blood sugar spikes as well. Another class of medications that are available are known as our DPP-4 inhibitors. Now, some examples of these do include sitagliptin, saxagliptin, linagliptin, and alogliptin. Similar to our other class of our sulfonylureas, these all do have a similar ending of liptin. And some common side effects of our DPP-4 inhibitors include headache as well as joint pain. More serious side effects that do occur with this class and can result in discontinuation of the medicine do include pancreatitis, UTIs or urinary tract infection, and then also heart failure. And then I do want to note that only saxagliptin has been associated with an increased risk of heart failure as well. The next class of medications we're going to look like only includes one drug, which is our Brandon or repraglidine. And these agents are to be taken by mouth before a meal to help decrease those blood sugar spikes. And then like sulfonylureas, they do have a potential side effect of severe hypoglycemia and then also weight gain. The next medication that we're going to look at is typically referred to as our TZD drugs. The most common TZD drug that we do have is pioglitazone or Actos, and they can increase the risk of bone fractures as well as cause fluid retention or weight gain. And then there is a serious adverse effect risk of bladder cancer and then also liver failure. Another class of diabetes medications that we do have include our Precoce and our Glycet. And these agents do have the potential to cause severe GI upset with increased flatulence or gas, and then also can have hypoglycemia or that low blood sugar levels with other agents. And some of these side effects do limit the use of these medications. The next medication we have is metformin, which is one of the most prescribed agents that we're seeing being utilized for diabetes. And it is commonly known for its ability to upset the stomach, but it does also have a few other side effects, which include such things as a metallic taste, a decrease in vitamin B12 levels, and a buildup of lactic acid. It is used in caution and will need to be more monitored in certain populations, such as those with kidney disease. Another medication that is available includes our amylin analogs, such as Simlin, which can actually be utilized in both type 1 and type 2 diabetes. This agent can cause severe hypoglycemia or low blood sugar levels, as well as nausea and weight loss. Simlin is administered as a subcutaneous injection, which is under the skin and is used 15 minutes before or at the time of meals. It is important to note that some patients may also discontinue this medication due to that severe nausea that was mentioned. Another popular diabetes medication includes our glucagon-like peptide 1 agonist, or also referred to as GLP-1s. This class includes such medications as liraglutide, dulaglutide, semaglutide, tirzepatide, and also our last one, Byetta. GLP-1s are used in patients with such disease states as diabetes, heart failure, or also chronic kidney disease. And they are known for causing such side effects as GI upset and then also weight loss. And then there are some more serious risk of side effects such as pancreatitis, gallbladder disease, and then also the possibility for thyroid cancer. Now, patients who are prescribed either our Victoza or Byetta will require an additional prescription for needles to use with the pens, as they are not included in the box. And then we do have at the bottom of your screen here, both that heart and that kidney on the bottom there, to signify which one of these GLP-1s that you can utilize for either that cardiovascular risk and then also for kidney disease, or that increased risk of cardiovascular death or that eGFR decline. The next class that we do have includes our sodium glucose cotransporter 2 inhibitors, or also known as our SGLT2 inhibitors. This includes such medications as dapagliflozin, empagliflozin, and canagliflozin. These medications do again have that similar ending as flozin to be easily remembered. And these medications do have risks of urinary tract infections, bone fractures, and then also increased cholesterol and ketoacidosis. They can lower weight and also blood pressure, and are also often used in patients with heart failure or chronic kidney disease. Similar to our GLP-1s, we have signified which of these agents that you can use in both of those conditions. Now we will go on to our third knowledge check. So feel free to pause the video at this time to review and then come back for the answer. Now, which of the following medications can be used for diabetes? This is a select all that apply question. A, metformin, B, acetaminophen, C, sertraline, D, repaglinide, or E, cholecalciferol. If you selected letter A, metformin, or D, repaglinide, you would be correct, as these are both utilized for diabetes. Acetaminophen is the generic name for Tylenol, which is an over-the-counter pain reliever, and sertraline is an antidepressant. And then our last medication we have on there are cholecalciferol. That is actually a vitamin D supplement. The mainstay of therapy for our patients with diabetes does include insulin. Now, while not all of our patients with type 2 diabetes require insulin, all patients with type 1 diabetes actually do need this medication to survive. There are many different formulations of insulin that do vary on their duration of action. Basal insulin is actually given once or twice a day to mimic that body's natural continuous release of insulin, whereas that bolus insulin is given at meal times to help curb postprandial glucose spikes. Insulin can come in different forms, including vials, pens, or cartridges as well. And most insulin preparations do fit in the category of either rapid acting, short acting, intermediate acting, long acting, or our ultra long acting. Rapid acting insulins do include insulin Lispro, which is Humalog, insulin Aspart, our Novolog, and insulin Glulicine, which is our Apidra. These insulins are subcutaneous as well, so under the skin, and utilize 10 to 15 minutes before a meal. You can see these insulins denoted as bolus insulins, or also you'll see some people call these mealtime insulins. Regular insulin, which is our Humulin R, is a short-acting insulin, and this is administered subcutaneously as well, and 30 minutes before a meal. Now, there are multiple different insulin formulations of the brand Humulin, so be sure to understand the difference between your Humulin N and your Humulin R, where that Humulin N is that intermediate acting basal insulin, whereas the Humulin R is that short acting bolus insulin to avoid a mix-up of the two medications. Insulin NPH, which is our Humulin N, that is our, again, intermediate acting basal insulin, and that is administered once or twice daily and also can be known as the nighttime insulin. Now, another nighttime insulin that they do have includes insulin glargine, which includes Lantus or Toujeo, which again is a long-acting basal insulin, and this can also be administered once or twice daily. I will now give it over back to Maddie to talk a little bit more about additional insulin options.
Okay, so the last insulin that we have here is the ultra long acting insulin. This one is insulin degludec or Traceba. This one is given only once daily because of that long duration of action, and it is given at night. So this slide is a review of the different durations of insulin formulations. It should be noted that Humulin N and Humulin R are the only insulin products that are available without a prescription. So you can go ahead and pause this slide for your viewing. And then we just wanted to take a moment to go over some other insulin formulations that are worth mentioning. So there actually is a pre-mixed human insulin bag that is available for intravenous or IV administration in the hospital. This one is not available for patients to use at home. It is only available when they are in the hospital, specifically in like the ICU setting. There also is a brand of insulin, Aspart. It's called Fiasp, and it is considered an ultra rapid acting insulin. It's not commonly used, but it is important for you to know that there is one that's even faster than our 15-minute ones. And then there is also an inhaled version of human insulin called Afrezza. So this one is actually used similar to like an inhaler that patients would use if they have asthma. So now we're going to take a look at the anatomy of an injectable medication. So our insulin pens and medications such as our GLP-1s come in devices such as this with slight variations. Much like a pen you write with, there is a cap at the top that must be removed prior to administration. Underneath where that cap had covered is a rubber seal and that medication reservoir. And there usually is a needle that needs twisted onto the medication. So that rubber seal should be wiped off with alcohol, like a little alcohol wipe, prior to attaching that needle. Most needles come in a small plastic cap where the base of the needle is exposed by removing a paper tab. And with the outer cap still attached, the needle can be twisted onto that pen. There is a small rubbery inner needle cap that must be removed prior to administration. And at the end of most pens is what is referred to as a dose knob. So this knob is used to both prime that pen and drop the medication. For insulin pens, you will drop 2 units and then press on the injection button to prime the pen. And for GLP-1s, you will drop to the first demarcation or line on that pen and then press on the injection button to prime the pen. Otherwise, patients will not be receiving the entirety of their dose because there will be a small extra amount left in the needle that should have gone into them. So now we're going to go over kind of what Ashley was talking about in regards of subcutaneous medications. So most insulins and GLP-1s are administered subcutaneously, which is an injection that goes just beneath the skin. It is important to clean that injection site with an alcohol prep pad or soap and water prior to administration. This is just to prevent any risk of infection when you are administering an injectable medication. So subcutaneous medications can be administered as in areas such as the back of the arm, top of the buttock, lower abdomen, or top of the thigh. You'll want to make sure you check the package insert or with a pharmacist just to make sure that the medication that's being administered is allowed to be injected in certain areas, because that can sometimes vary. And it is important that the needles and syringes are never reused, either with like a provider administering medications or a patient self-administering a medication, as this poses a greater risk of infection. And it is important to rotate those administration sites between each injection. That's just to kind of help reduce any of that inflammation. And there is a risk of contracting and spreading bloodborne pathogens, such as hepatitis or HIV when working with needles. So it is very important to practice good safety measures. Now we're going to go over a little bit. I know it seems simple, drawing up insulin with a syringe, but unlike most medications, which are measured in grams or milligrams, insulin is measured in units. So most insulin products are 100 units per milliliter. This is also referred to as U100. And insulin is often dosed in much, much smaller units than 100 units. So we need to be mindful of that difference in volume when preparing insulin doses. So insulin is typically drawn up in either 1 ml syringes, which is demarcated by 0.1 milliliters, or there is specific U100 insulin syringes, which are demarcated by tens. So we have what 22 units would look like in a 1 milliliter syringe. So you can see that it says 0.2 instead of 22, as well as what 11 units looks like in a U100 syringe, where it actually shows that 11 versus the 0.11. And I wanted to go over just a quick potential insulin error here. Insulin can come in much more concentrated units, such as U300 or U500. So we want to make sure we are checking our concentration prior to handling, because administering too high of a dose of insulin can result in life-threatening hypoglycemia. So that is a potentially lethal error that we want to make sure we prevent. Here we have the administration technique for preparing insulin from a vial with a syringe. So if we are using a new vial, we need to start by removing the little plastic top or cap from the vial. Then we need to wipe it off with a little alcohol swab, waiting a few seconds for that alcohol to dry. So while waiting for that alcohol to dry, you can get your insulin syringe prepared. For the U100 insulin syringes, that just involves removing the cap. And then we can draw up that number of units using air, not insulin. So we will then puncture the top of the vial with the needle facing down, and we're going to expel the volume of air that we just pulled up into the vial. So expelling this air into the vial will help displace that liquid from the vial into the syringe a lot easier, and it helps just prevent the vial from becoming too pressurized over time. You'll then flip the vial and the syringe together so that the needle is now pointing towards the sky. And we'll want to actually draw up our amount of units of insulin required by pulling the plunger down. So you will likely need to draw out more insulin than what is needed because there will be bubbles. So you want to use your hand or finger to tap or flick the syringe to get rid of any excess bubbles. Then you remove the needle from the vial and the insulin is now ready to be administered. So this is the injection technique for using pens. So we just went over vials. Now we are going over pens. So again, injectable pen medications are usually insulin or a GLP-1. The cap must first be removed, and then a needle will be twisted on the pen, just like I went over earlier when talking about the anatomy of an insulin pen. And then that needle must be primed to ensure that all of the dose will be administered. Like stated earlier, there is that paper seal on the edge of the cap that's covering the needle that needs to be removed prior to twisting the needle onto the pen. Then both the outer needle cap and inner needle cap need to be removed. And just like I said earlier, that needle is primed by twisting the dose knob to the first demarcation, or 2 units if it's an insulin pen, and then by pressing the injection button. So a small amount of liquid may escape the needle, that's okay. We just want to make sure that enough is in there to where the whole dose can be administered. So then we are ready to turn our dose knob to the correct dose, and the medication is ready to be given. And then I want to talk just a little bit about insulin pumps. So these are small computerized devices that are worn on the outside of the body and can be used to assist patients in managing their diabetes. So the delivery of insulin through insulin pumps is intended to mimic that body's normal release of insulin, and they are connected to the body via an infusion site where a small plastic tube called a cannula enters the skin to deliver insulin into the body. All right, now we are at learning check 4. This is a question about insulins. So again, feel free to pause the recording until you have your answer. Which of the following are mealtime or bolus insulins? This is another select all that apply. We have insulin Lispro, NPH insulin or Humulin N, regular insulin or Humulin R, or insulin glargine. So the answers here are insulin Lispro and regular insulin. NPH is an intermediate acting basal insulin, and insulin glargine is a long acting bolus insulin. I am now going to pass it over to Haley so that she can discuss some monitoring, diabetes technology, complications, as well as some resources.
So, like Maddie said, I am Haley. Looking at monitoring, one of the main ways diabetes is monitored is by looking at blood sugar, and there's a variety of different tests we can conduct to assess blood glucose levels. So the first test is a fasting glucose reading collected after a patient has gone 8 hours without eating. This is a lab draw done at regular health visits. The next glucose test is random glucose or point of care glucose reading. These can be done at home by patient or by provider at any time. Some patients even have continuous glucose monitors, CGMs, that monitor a person's blood sugar continuously throughout the day. Preprandial blood glucose should be between 80 to 130 milligrams per deciliter, and postprandial blood glucose should be less than 180. The final glucose test is the hemoglobin A1C. So this is a lab that's collected every 3 to 6 months to assess the average glucose level over a longer period of time, over 3 months. The goal A1C for a person with diabetes is less than 7%. So this is a chart comparing the average blood glucose with how it correlates to an estimated A1C level. Naturally, the higher the average blood glucose is, the higher a person's A1C will be. So again, indicated by that blue, our goal A1C for a person with diabetes is less than that 7%. So every patient with diabetes should have access to a portable glucose monitor. These are helpful for regular blood sugar monitoring, as well as detecting if someone is hypoglycemic or hyperglycemic. Most portable glucose monitoring kits come with a glucose monitor, a lancing device, lancets, test strips, and even a convenient carrying case. Some kits also come with ketone strips, which can be used to test in the urine to see if there's glucose or ketones, which are common signs of hyperglycemia. This is a brief video demonstrating how to use a glucose monitor. Aside from insulin pumps, another wearable diabetes device is a continuous glucose monitor, or CGM. They're a small device with a plastic tube that enters the top of the skin. They continuously monitor a person's blood sugar and can even be set up to connect to smartphone devices to alert people when their blood sugar gets too low or too high. They are typically replaced every 7 to 14 days and require a transmitter. On some CGMs, the transmitters are integrated into the device itself, and on others, they are a separate piece that has to be connected. The receiver, which can be a smartphone or another remote-like device, displays the glucose readings and can be a part of an insulin pump. It also often includes features like trend tracking, alarms for low or high blood glucose, and sharing to other smartphones for family and provider glucose following. There are many types of insulin pumps and CGMs. Some can even work together in a feedback loop or a looped system to help patients manage and monitor their blood sugar. They also record time and range values, which can be used as a goal and can also be used to correlate to estimate A1Cs. Additional supplies. This slide is a comprehensive list of supplies used by a patient with diabetes. As you can see, the management and monitoring of diabetes can be very involved. Most of these supplies are available over the counter, but patients may experience less of a cost burden if these supplies are filled and sold as prescription items. And this list is not all inclusive, of course. Another important aspect of diabetes management is reducing the risk of complications. Complications of diabetes include macrovascular complications and microvascular complications, which are listed out here, as well as, of course, hypoglycemia, low blood sugar, and hyperglycemia. Looking at complications of diabetes, prolonged, inadequately controlled glucose levels can contribute to numerous macrovascular and microvascular complications. Macrovascular complications include cardiovascular diseases such as stroke, heart attack, and coronary artery disease. Microvascular complications include neuropathy, like nerve pain and damage, nephropathy, which is kidney damage, retinopathy, which is damage to the eyes, foot infections, and skin and mouth conditions, infections. Hypoglycemia is defined as a blood glucose that is less than 70 milligrams per deciliter, and treatment for hypoglycemia is synthetic glucagon or food containing carbohydrates. Clinically significant hypoglycemia is defined as a blood glucose that's less than 54 milligrams per deciliter, or any hypoglycemia that is symptomatic. Common signs of hypoglycemia are sweating, pallor or paleness, hunger, fatigue, irritability or anxiety, rapid heart rate, and poor concentration. Severe hypoglycemia can result in coma or even death, and all patients who are at risk of clinically significant hypoglycemia should be prescribed synthetic glucagon. Hypoglycemia can occur for a number of reasons, including alcohol consumption, strenuous physical activity, and skipping meals. Certain medications can also contribute to hypoglycemia. This is such as beta blockers, which are medications that tend to end in that olol suffix, and even some antibiotics. All diabetes medications can cause hypoglycemia, but the biggest offenders are the peglinide, SGLT2s, inhibitors, sulfonylureas, and pioglitazone, as well as insulin. And certain combinations of glucose-lowering agents can greatly increase the risk of hypoglycemia, such as metformin and sulfonylureas. For conscious people experiencing hypoglycemia, we follow a 15-15 rule. So step 1 would be testing the blood glucose. If blood glucose is less than 70, they need to consume 15 grams of fast-acting carbs. Fast-acting carbs include things like glucose tablets, glucose gel, 4 ounces of juice or a non-diet soda, 1 tablespoon of sugar or honey, or even certain hard candies. Then the person should wait 15 minutes and then test their blood glucose again. And repeat until blood sugar remains over 70. For severe hypoglycemia or for patients who are unconscious due to hypoglycemia, they need to be given synthetic glucagon. Synthetic glucagon can come in both intranasal forms as well as intramuscular forms. So it's important that people who are around people with diabetes are trained on how to administer synthetic glucagon and to know where patients keep their synthetic glucagon. Hyperglycemia, on the other hand, is defined as a fasting blood glucose greater than 125 milligrams per deciliter or a 2-hour postprandial glucose of greater than 180. While hyperglycemia may not be immediately dangerous, inadequately controlled blood glucose can precipitate those numerous complications of diabetes we discussed earlier. Blood glucose can also reach threateningly high levels and present with complications such as diabetic ketoacidosis or hypoosmolar hyperglycemic state. Symptoms of hyperglycemia include severe hunger, thirst, tiredness, increased urination, slow healing of wounds or infections, and blurry vision. The final piece of comprehensive diabetes management is problem solving. This includes highlighting the importance of multidisciplinary care, as well as recognizing special populations that require more individualized treatment. This can include patients with diabetes who are pregnant, female, or young adults. All patients with diabetes should engage in care with a diabetes education specialist, pharmacist, dietitian, and endocrinologist. Depending on their comorbidities or those diabetes-related conditions, they may need to see other providers as well. Patients with cardiovascular disease need to see a cardiologist. Patients with chronic kidney disease should see a nephrologist. And patients with diabetic retinopathy should see an ophthalmologist. It's important to remind patients with diabetes that their condition often requires multidisciplinary care. Sometimes pregnancy can precipitate diabetes, which is known as gestational diabetes or GDM. It's important that pregnant people have medications to manage their diabetes that are deemed safe for both them and the fetus. Initial treatment of diabetes in pregnancy involves medical nutrition therapy with individualized meal planning, regular physical activity, and other lifestyle modifications. If pharmacotherapy is needed, insulin is the preferred medication due to the lack of risk of fetus being exposed to the medication. Any oral medications that may be considered require the direction of a pharmacist or primary care physician. Pregnant people with diabetes require frequent self-monitoring of blood glucose levels to ensure their own safety as well as the safety of their baby. While there are guidelines for the management of diabetes in pregnant women, there is little guidance on managing blood glucose during other phases of the reproductive cycle. Hormonal changes can affect insulin sensitivity and glucose control. Many people who menstruate with diabetes lack access to pre-pregnancy counseling, contraceptive guidance, and hormone replacement therapy. So that would need to be considered as well. Another special population to mention is young adults, specifically those aged 18 to 30. There are additional resources for this population such as the Diabetes Link, which provides peer support resources for college students and young adults and advocacy measures. This was also previously known as the College Diabetes Network. So, to conclude our section 3 wrap up, let's go over a few more diabetes resources for both patients and providers, as well as discuss your role in diabetes management as a community health worker. There are numerous patient care resources for people living with diabetes. There are podcasts such as the Juice Box that blends personal stories, expert reviews, and practical advice to help listeners manage their condition with confidence and clarity. There are also nonprofit support groups, such as the Diabetes Sisters, that host webinars and workshops on nutrition, medication, and lifestyle. Patient resources are all about fine-tuning the needs to your specific patients and providing them with continued support and advocacy. There are also quite a few places that healthcare professionals and providers can go to learn more about diabetes management. The CDC creates infographics and publishes data pertinent to the field of diabetes, as well as hosts the National Diabetes Prevention Program. The American Diabetes Association, or ADA, also publishes the standards of care guidelines for providers to follow. The Association of Diabetes Care and Education Specialists also creates resources for patients and providers alike to provide comprehensive diabetes care. So let's discuss how everything we learned will play into your role as a community health worker. One of your responsibilities will be asking patient questions about the management of their diabetes. Examples of questions to ask include: what side effects are you experiencing with your medications? Did you stop taking any of your medications? Are any of your diabetes medications affecting your quality of life, and how so? Did taking your medicine have positive effects on your health? Did your medicine cause low blood sugar or glucose? Are you concerned about the number of pills you must take every day? And is your medication plan too complicated for your lifestyle? Another role as a community health worker is to help patients implement the ABCES 7 self-care behaviors, delivering diabetes self-management education and support, and helping patients understand blood glucose monitoring, medication adherence, nutrition, and physical activity. And of course, supporting your patients. Supporting patients in adopting healthier habits and overcoming cultural or emotional barriers to change, reducing health disparities, and supporting patients in adopting healthier habits and overcoming those cultural or emotional barriers to change. We thank you for taking the time to learn with us about diabetes care and taking the time to review this presentation to help your patients. And here are our references that you may visit as well.